Okay, let's discuss palpation-based orthopedic procedures for primary care. No disclosures. The objectives are essentially to review common palpation-based procedures for commonly seen orthopedic conditions in the primary care office. And then using a case-based approach, kind of identify which patients are appropriate, discuss the inject dates and reasons for choosing or not choosing them, and then just additional clinical pearls. So what is included in this lecture is knee, subacromial bursa, trigger point, trigger finger, carpal tunnel, de Quervain's or first dorsal compartment, tennis elbow, a C joint, and subglute max. Ultrasound is needed for a lot of other injections such as the shoulder, the biceps tendon sheath, the hip, and of course many more. Contraindications to injection. So there's some absolute, right, allergy to injectate, whether that's the steroid or the anesthetic or any other component, systemic or local infection. Prosthetic joints should not be injected. And if there's any fractures there, it should also not be injected. Relative contraindications include coagulopathy or anticoagulation, poorly controlled diabetes, immune suppression, abnormal anatomy, or generous body habitus can make a lot of injections more challenging, and then no relief from previous injection. What equipment do you need? Well, alcohol wipes, although I usually have betadine or chlorhexidine as my sterile prep, gauze, a syringe, a draw needle, an injecting needle, the medications to be administered, typically a steroid and anesthetic. Also not pictured are a Band-Aid after you're done. You need gloves, and then patients love the ethyl chloride cold spray. So let's talk about local anesthetics briefly. Most commonly you see lidocaine, bupivacaine, ropivacaine. You do not need epinephrine. And then of which of these is the best? Well, ropivacaine has been found to be the least chondrotoxic and least toxic to the tenocytes as well. So if you have a choice, ropivacaine is probably your best option. In terms of steroids, I don't know that there is a best steroid when you're talking about injections. You have to modify your dosing a little bit depending on what you use. I would say triamcinolone, which is Kenalog, is probably the most common, but all of these are reasonable choices. I'm the most familiar with Kenalog, so I'm going to use that dosing regimen as I discuss specific joints. A comment on Toradol or Ketorolac. Okay, we did a narrative review looking at Ketorolac for musculoskeletal conditions and injections, and basically found that there's quite a few papers that support its efficacy for common conditions such as subacromial bursitis, frozen shoulder, hip and knee arthritis. And then also a comment on hyaluronic acid, somewhat controversial. The best review articles do show benefit for pain, stiffness, and function up to 6 months. Patients who get platelet-rich plasma or mesenchymal stem cells seem to do better. The big feared complication is pseudo-septic arthritis, where they present with a very much of a septic arthritis picture, but it's really just a really profound inflammatory response to the injectates. And it can be difficult to get insurance to approve, so often the juice is not worth the squeeze. However, a lot of your joint surgeons will require this injection prior to total knee arthroplasty. Okay, let's get into some cases. So 67-year-old moderately obese male presents with knee pain. He's had it for years. It's slowly getting worse. He's taking Tylenol and ibuprofen, but states he's going on a trip with his family soon. So we'll start with the knee injection here. Typical indication is knee arthritis. There are, of course, others, but that would be the most common. And the way that I approach this is the anterolateral approach, which is my recommended advice for this injection, although you can inject in other places. Essentially, you want them seated with the leg hanging off the table. Gravity can help you distract the joint. Identify the inferior pole of the patella and the patellar tendon, which are marked here, and then move out laterally. Find the lateral femoral condyle, which is marked in the tibial plateau. And that essentially creates a triangle for you to inject in. You're going to want a 1.5-inch needle with a 21 or 22 gauge and roughly 5 cc's of anesthetic and 40 milligrams of Kenalog. And the neurovascular bundle is in the popliteal fossa, so it's very much impossible or nearly impossible to cause any catastrophic injuries if you inject from the front. All right. A 47-year-old female presents with acute onset of atraumatic left shoulder pain. She has pain with passive and active abduction and a positive empty can test. Otherwise, her exam is intact. So let's talk about subacromial bursa injection. The indication is rotator cuff pain, whether you call that subacromial bursitis or rotator cuff tendonitis, even rotator cuff tears in older patients. Essentially, you want to find the posterolateral corner of the acromion, move about a finger width down, and then your vector for that injection is going to be to aim at the coracoid process. And I will often have my index or middle finger on that spot. You want to use a 1.5-inch 21 or 22 gauge needle, and you use about 5 cc's of anesthetic and 40 milligrams of Kenalog. And the big thing here is just to aim towards the coracoid process. You're typically going to hub the needle and inject, and if you feel resistance, inject as you back out until you feel it flow freely, and you will know you're in the bursa. If you hit bone, you just have to vector up or down a little bit depending on whether you're thinking you're hitting the shoulder joint or the inferior border of the acromion. A 44-year-old hairdresser presents with neck pain radiating down her left arm. On exam, she's exquisitely tender along most of her trapezius and the medial border of the scapula. So let's talk about trigger point injections, okay? Indication of myofascial pain or trigger point pain is sort of subjective, I think, but in the right patient, these are very helpful. And you want to mark and sterilize the areas that are tender, inject as needed, okay? I usually use a 1/2-inch 25-gauge needle, and I put about 1 cc of anesthetic in each myofascial trigger point. And you can inject really as many as you want as long as you stay under the toxic dose of lidocaine or whatever injectate you're using. And then make sure to document the trapezius, levator scapularis, and rhomboids to get 3 muscle groups for billing. A 74-year-old female presents with finger pain. She states her pointer finger clicks and gets stuck in flexion. She states this happened once before, but it went away after she got a shot. So she, of course, has a trigger finger, okay? The technique here is to basically mark the tender nodule. So you're going to go on the volar surface of that finger and palpate around the MCPJ, which is about where the A1 pulley is. And wherever she's really tender, you want to mark the skin there, and that'll be your injection point. So sterilize, and then approach proximal to distal at about 30 degrees off the skin. You can do distal to proximal as well. This is just my approach. And then basically you inject until you hit bone, and then back up a little bit and inject until it starts to flow freely. And you will sort of with a tactile feel know that you are in the tendon sheath. You only need a 0.5 to 1-inch needle and a 25 gauge. Not a lot of volume here, right? So max of 1.5 cc's, but typically I'll draw up 0.5 of the anesthetic and then 20 of Kenalog, which is 0.5 as well. A 34-year-old female computer programmer presents with bilateral hand paresthesias. She said that this has been going on for months, and she has a positive Durkin's test. So we are, of course, talking about carpal tunnel. In terms of who you inject, that's somewhat subjective in the decision-making tree, typically not first line. But when you decide, you want to find the palmaris longus tendon. You want to inject about 30 degrees off the skin from proximal to distal, aiming at the ring finger. If the patient experiences any paresthesias, you want to withdraw and redirect in a more ulnar direction. Use a 1.5-inch 25-gauge needle. And again, not a ton of volume here, 1 or 2 cc's of anesthetic and 40 milligrams of Kenalog. A 27-year-old ultrasound tech presents with pain at the base of her right thumb that radiates up her forearm. She has a positive Finkelstein's test. We are, of course, talking about the first dorsal compartment, or more commonly called the Quervains. Okay. Basically, you want to identify the first dorsal compartment with a thumbs up maneuver. That'll help you find the tendon sheath and your target, which is marked in purple on the picture. You want to aim the needle down the tendon sheath about 30 degrees off the skin, distal to proximal. And the big thing is if you're in the right spot, you will see the fluid track down the tendon sheath. You kind of sometimes have to advance or withdraw the needle just a little bit to make sure you're there. Typically, you use a small needle, 0.5 inches, 21 or 22 gauge, and you don't need a lot of volume, 1 or 2 cc's of anesthetic, and then the Kenalog. I will typically put these patients in a thumb spica splint or brace for a week or two after this to wear all the time to help with inflammation and basically just reduce use of the tendon. A 54-year-old female presents with lateral elbow pain. She says it started when she took a new job as a housekeeper, which has gotten worse over the last few months, and she has a positive Cosen's test. So in this patient, we're talking about tennis elbow or lateral epicondylitis. This injection has gotten more controversial as time goes on, as tennis elbow is really no longer thought of as an inflammatory problem. However, this injection is still performed. The arm should be resting on the table, elbow flexed to 90 degrees as in this picture. Identify the point of maximal intensity or tenderness on the lateral epicondyle, and then you're going to slide just distal to that and enter proximal to that tender point, advance to the bone, and then pepper the tendon with your injectate, okay? 1.5-inch needle, 21-22 gauge. And you don't always need 5 cc's. This is probably more like 3, but also add in the catalog there. A 49-year-old former powerlifter presents with atraumatic right shoulder pain. He is point tender on his AC joint and has a positive cross-arm test. So we're talking about the AC joint in a patient who has probably degenerative changes from heavy weightlifting. It can also be diagnostic in some patients when you're not exactly sure what their pain source is. Finding the AC joint is typically pretty easy. You just walk up the clavicle and find the tender spot. You want to make sure you find the edge of the acromion as well. Aim inferior, and if you have a short needle, you really don't have to worry about going through the entire joint. You should feel the needle drop in, so sometimes you have to redirect medial or laterally just a hair until you feel it pop into that joint space. You'll know, and then you can inject, right? So use a small needle and max of 1.5, 2 cc's of total injectate. A 39-year-old female runner presents with right hip pain. She has pain with abduction and hip extension. She's point tender on her greater trochanter. She, of course, has trochanteric pain. It's a little controversial in what we call this these days. I think trochanteric pain syndrome is the most commonly accepted vernacular. If you do want to inject, you want her in the lateral decubitus position. You're going to find the point of maximal intensity along that greater trochanter, and that's essentially your target. You're going to aim there. You're going to vector your needle a little anteriorly, and the reason is if you overshoot, it's okay to go into the anterior soft tissue. If you overshoot posteriorly, you got to worry about the sciatic nerve. You don't want to fenestrate that. So you're going to use a 1.5-inch needle unless they're really obese. 21 or 22 gauge should cut it. And this one's a little bit higher volume, so 5 cc's with probably 40 milligrams of catalog.